Dear Chair, dear guest, allow me to present our progress. My PhD topic is exploring HPV-associated diseases in different anatomical areas and their preventive measures. My name is Adél Mózes. I'm a first-year PhD student from the Department of Pediatric Dentistry and Orthodontics. My mission is to decrease the prevalence of HPV-caused diseases, and my vision is to find the best options for HPV prevention and detection. Allow me to introduce our two specific goals. Our first is to reveal the prevalence and risk of oral HPV infection in cervical HPV-positive women through a systematic review and meta-analysis. And our second one is to analyze the concordance between oral and genital HPV within a single center post-hoc cohort analysis. So let's jump to our first project. As you know, HPV is the most common sexually transmitted pathogen of the 21st century, causes more than 5% of the cancers worldwide. Beyond cervical cancer, HPV can also cause oropharyngeal and other genital cancers. In addition, the prevalence of oropharyngeal cancers caused by HPV has quadrupled in the recent years. Therefore, our aim is to identify the association between cervical and oral HPV infection. Our first question is, what is the prevalence of oral HPV infection in females with cervical HPV? We are using the CALCOPO framework, and we hypothesize that females with cervical HPV infection have a high prevalence of oral HPV. And our second question is, does cervical HPV infection increase the risk of oral HPV infection in females? Here we are using the PICO framework, and we hypothesize that cervical HPV infection increases the risk for oral HPV in females. Here you can see our systematic search, which we conducted in 3 separate databases on November, with this search key below. After the selection, we ended up with 41 eligible full text. As you can see, we finished the primary outcomes analysis, and we are working on our secondary outcomes and the subgroup analysis. One of our primary outcomes, which we measured in odds ratio with a 95% confidence interval. So here we measured how many women had oral HPV in the cervical HPV positive versus the cervical HPV negative group. We were able to include 34 articles with more than 5,000 patients. Prospective cross-sectional studies were included. As you can see, the heterogeneity is 39%, which is a moderate heterogeneity. And the reasons of the heterogeneity could be the different oral sampling methods, the different virus detection kits, the globally and individually different sexual habits, and the HPV positivity or negativity of the sexual partner. And our result is the odds of having oral HPV among females with cervical HPV is 2.22 times higher compared to the cervical HPV negative group. Our result is clinically and statistically significant. And our other primary outcome is the prevalence, which we measured in proportion with a 95% confidence interval in the cervical HPV negative and the cervical HPV positive group. We were able to include 34 and 41 studies with more than 2,000 and 4,000 patients. Prospective cross-sectional studies were included. The heterogeneity was quite high. The reasons can be the same as I explained. And our result is that the prevalence of oral HPV among females without cervical HPV is 4%. And the prevalence of oral HPV among females with cervical HPV is 13%. Our result is clinically significant. As you can see, according to the international literature, the oral HPV carriage is between 5 and 10%. Our biggest limitation is that there is not a standardized oral sampling method, and they are using a little bit different test kits, which led us to a high risk of bias. But this is why we set a minimum requirement, which says the genotypes in the Gardasil 9 vaccine must be tested in our included articles. Also, we are presenting worldwide data and performing subgroup analysis. Based on our results, we can conclude that females with cervical HPV have a 2.2 higher odds for oral HPV positivity, and 1 out of 8 females with cervical HPV have oral HPV positivity too. It suggests that there is a need to raise awareness of the oral presence of HPV. Also, the oral protection of the HPV vaccination should be emphasized, and perhaps it would be advisable to also screen the oral cavity of the cervically positive women, and maybe it's time to develop a valid oral sampling method for HPV sampling. Here you can see the first project progress. We are working on some additional figures, and we have started the manuscript writing. And let's jump to our second project. As I mentioned, the prevalence of oral HPV at the population level is between 5 and 10%. That's why FDA does not recommend oral HPV screening at the population level. Despite all of these, the prevalence of HPV-positive oropharyngeal cancers is steadily increasing in the Western world. Therefore, our aim is to identify the concordance between genital and oral HPV infection. That's why our question is, what is the concordance between oral and genital HPV in HPV syndrome patients? We are using, again, the CALCAPO framework, and we hypothesize there is concordance between genital and oral HPV infection. The clinical implication would be to determine who should be screened for oropharyngeal cancer prevention. We are in the data collection phase. We have more than 4,000 patients' data who visited this centrum. All of them had some HPV risk, so we are here not studying the general population. Our inclusion criteria are females and males aged between 18 to 70 who are not immunocompromised and have both the genital and oral HPV samples. We would like to study the HPV concordance in different body parts of an individual and also between partners. Here you can see our summary of our aims with the planned submissions. And I would like to thank you for your attention with the quote from Albert Einstein: "The more I learn, the more I realize how much I don't know." Thank you.
I have a question because you said there is no standardized way for the sampling, and therefore I have two questions. What's wrong with the method that they use right now, and what would be your suggestion? How would it look like if it's fine?
Okay, so nowadays they are using two techniques. The one is the oral brushing, when they are brushing the mouth and the oropharynx. And the other one is the oral rinse, when they are using some liquid, water or alcohol-based generally. The problem is they are not validated tests, so we don't know that is it a real negative or a false negative test. These tests, so when they are performing the PCR, these PCR tests were validated for the cervical HPV screening, and in the cervix, the copy number of the HPV virus is enormous. In the oropharynx and the oral cavity, it's not. So I think we have a lot of false negative tests.
Do you know something about that? Is there any difference of concordance in different serovariants of HPV infections? Like, do you have some information or some literature about the low risk or the high risk HPV infections?
Okay, so high risk can cause cancer, low risk causing genital condyloma or condyloma on the genital area or in your oropharynx or oral cavity. So we are afraid of the high-risk HPV types.
And do you think is there any difference in concordance between the low-risk or the high-risk?
We are planning to study this. Thank you.
Do you know what's the ratio of oropharyngeal cancers, HPV positive and negative in Hungary?
Yes, thank you for your question. So we differentiate HPV positive and negative oropharyngeal cancers. In Hungary, we don't know the exact data, but I have talked with an HPV specialist, and he said that in Hungary, 1/5 of the oropharyngeal cancers are HPV positive in men, while in women, half of them HPV positive.
What do you think were the main reasons for such a difference in the prevalence in the first plots, for example, of some studies? Could you somehow analyze them separately to address these differences somehow?
You mean the cervical HPV negative?
Yes, I think the first plot about
yes,
the prevalence.
so it's a risk to have cervical HPV because during sexual activity you can be easily infected to your throat.
Then some studies had a much higher prevalence than some other studies. So I'm asking about the heterogeneity that you had in your first plot, especially. And do you think there's anything that you could do to address this better in the analysis? Do you understand my question? In your first plot, you had some studies that were pulled much more to one side than the other. Yeah, for example, we have the Grimm study, which has an OR of 0.47, and then Crawford has a 93.71. So you have a huge difference between those studies. So I'm just wondering what was the reason behind this, and if you think that, for example, you could subgroup somehow by these reasons so we could see them separately so this is not affecting the pooled effect.
Mm-hmm. Okay, so in some cases in the lower end they use nested PCR, which is it's more sensitive than the regular PCR, and also they had a positive cytology population. So this can be the reason, although Tatar in the middle had a population with positive cytology women and also used nested PCR, and they didn't have the large numbers. So yes.
Do you think it will be possible to subgroup them by the type of PCR that was done, or how the diagnostic was done?
We are planning to subgrouping them based on the oral sampling methods, and also we are planning to separate the brushing methods that they perform the brushing in the oral cavity and or in the oropharynx, and we will see.